Well, welcome. Today we're going to talk to two of the people who directly impact our lives and the lives of our family in very positive ways. So why don't we start with introduction?
Hi, Al. Glad to be back. I'm Pat McSweeney. I'm now a senior vice president of UMass Memorial Medical Group and the executive director of Milford Regional Physician Group. So glad to be back.
Which employs what, about 90% of the physicians in the Milford area?
Yeah, just about that. Yeah.
There's got to be one out there that isn't. I haven't run into him.
There's still a couple of independents out there. Yeah.
Hi, Al. Ed Kelly, president here at Milford Regional. Been at Milford Regional for 33 years. So thanks for having me back.
The question that I guess it's been a year and a half with UMass,
A little more than a year and a half, yep.
how's it working?
So overall, it's going really well. Behind the scenes, there's a lot of changes going on. And what we're hearing and hoping in terms of the community is things haven't changed very much. So that's really kind of a win for us. So we're really trying to preserve what's been special about Milford Regional. The hospital and the physician group, even though there's some changes, we continue to work very closely together and are interdependent on each other. So again, integration has been really the big theme since we've joined UMass Memorial.
Yeah, I would echo what Ed said. I think hopefully most people haven't noticed much change and still getting the great care from the great providers and staff that they always have. I think behind the scenes there's been a lot of change. I think going from being small independent to being part of a big organization has its changes and challenges, but hopefully we're dealing with those, and sort of the patients and the frontline caregivers are not dealing with so much of that. But I think the better way to look at it is, what would things have been like if we hadn't made this move? And I think that's something that in some ways you don't really want to think about, because I think things would have been a lot different and not in a good way if we had been struggling to remain on our own. I think we would have had to make some difficult decisions.
Could we have stayed on our own?
We really couldn't have without dramatic changes. As you know, after in our first year of COVID, because of government relief, our loss was $5 million. So I remember saying in a number of forums here, this, we're going to recover from this. But then, as time went on, the losses went up a lot, not because we were doing worse, but because the government subsidies to relieve COVID stopped. And then after like 3 years of losses, we said, hey, this isn't really sustainable. We either need to dramatically change who we are, or we need to join a bigger system, like, frankly, most community hospitals our size and even bigger had done. So I think to answer your question, it wasn't sustainable. And then by the time we joined the system, we had actually 5 years of losses. So it validated that we made the right decision.
Well, I think everybody agrees, because at $5 to $7 million, $7 to $10 million a year, the lines kind of cross each other.
That's right.
And something's got to give, either quality or price, and you can't increase the price because your biggest customer dictates the price.
The first thing that stops is your so you have revenues and expenses, but you use your bottom line to fund capital acquisitions. So when that stops, it's a matter of time before things deteriorate. And so I think in my time at Milford Regional, we had always been proud that we've really kept up our facilities. A part of that has been the community support in terms of any major project we did, the community supported. But really, we used our success to fund our future. And with the COVID losses, that had stopped and was going to continue to get worse. And we would just see a decline in terms of our physical plant equipment, the stuff that you really want to keep state of the art.
Well, I mean, you start thinking about little toys like Da Vinci. What does that run now, $2 million?
Yeah.
When you start talking about investing in routine equipment and it's in the millions, I can't see how we could have sustained it.
Right.
And if we don't sustain it, all of a sudden our claim to fame is that you can get the same care here as you do in Boston. Without the equipment, the physicians don't have the state-of-the-art tools. And then how do you draw state-of-the-art physicians?
Right. And just to clarify, what we want to be is a great community hospital. So to know our scope of services, both hospital, physician, and, to have great physicians, 5 urgent care centers, great hospital services, that's really what we want to be good about. So we want to have the latest technology in those services, but then have these relationships with Boston and Worcester in terms of a higher level of service.
And I think having the latest technology doesn't have to be in Milford. I remember when I went down for my stress test, I had no idea, but within an hour and a half, I was on an ambulance on the way to the Brigham to get a quadruple bypass. I really didn't care where it was done. The fact that they were able to diagnose it, because when they said, well, we need to do some procedures, I said, well, let me check my calendar. I'm sure I can find some time next week. And the physician there looked and said, no, we're talking the next couple hours. And, and the thought comes to your mind, well, I'm in Milford. Should I be in Boston? Well, apparently I should have been because they transported me right there. So I couldn't ask for better than having access. How is those relationships now that we're part of UMass? Has that changed much?
We've enhanced our services with UMass. So in terms of, one of the things that really was the early bridge with UMass is our teaching programs. And so to have residents and medical students, and those programs are growing and getting stronger, and we're looking to grow them. And really, that's great kind of infrastructure, but it's also building a future of recruits, people that come to the community, work in the community, like the community, and so that's kind of one positive. But on many clinical areas, we're expanding our services with UMass, and again, trying to do what's appropriate in the community hospital. Kind of the good news is things are jammed in Worcester. They're just too crowded, too busy. And so this notion that, they just want our patients is not true at all. In fact, we're trying to continue to keep, the appropriate patients in Milford to actually help UMass, because we want UMass to take the really sick patient, not the routine patient.
The ones that need really specialized care.
Right.
And I think that's what most patients would want too, because given the choice, I would rather stay in Milford. For years I mentioned my mother when she went through her cancer surgery. Driving her down West Street was a lot better than driving the Mass Pike. Just not mentally. It was her hospital, her town, and it was a 10-minute drive. She wasn't showing up already full of nerves. So now you're part of UMass. Do they still worry you're the biggest talent thief?
No, we're doing pretty well with that. It's a two-way street, right? So we have some people go up there. Sometimes they have some people come down here. To follow up to the question that Ed answered, I think we will start seeing some more of the UMass specialists coming down here, spend some time in our ORs maybe where there's a little bit more access than they have in Worcester. We also are part of a regional program where finding open beds at any of the hospitals that have open beds instead of them laying in hallways in Worcester. We're actually accepting patients from either Worcester or maybe community ERs in the rest of the UMass system to fill beds. So it's keeping patients out of hallways in ERs or hallways in other parts of hospitals when one hospital is more full than another.
But it always seemed, you say it's a two-way street, it always seemed that you welcomed the physicians here,
yeah,
and then you seemed to keep them.
yeah, yeah, yeah. Well, now we don't have to. Now we don't have to take them full time. We can share them.
Oh, even better.
Yeah, yeah. So we already started that. We currently share an ENT doctor. 50% of his time is in Worcester, and 50% of his time is here in Milford, and that's worked well. And we're looking to model that in some other specialties as well.
Well, it would seem that that would open up some opportunities for us because, you go, Uncle Ed, I need to buy a physician that does this. And he says, but I can only afford half of them. Well, this would seem optimum that you could fund half of them or a third of them
Yep.
until the practice grows.
Yep, and that's exactly what we've done in ENT so far, and that's working out well. So we're looking to do that in some other specialties as we speak.
Do we still have the relationships with the Farber and Brigham and all of those other?
So one of the things heading into announcing that we were joining the UMass system was what's going to happen in cancer. And fortunately, timing is everything. And right before we announced, Dana-Farber announced that they were kind of changing, their corporate strategy. So they were in Boston, which is really where there's a little bit more tension. They were going to be leaving their services with the Brigham, which provides the inpatient service, and move it over to BI, and it's still a few years out. So that's a tense point. But in addition to that, they announced that they were really going to work with all parties, not exclusively the Brigham. So Beth Israel and UMass. So for us, and continue with the Brigham. So for us, that's a big positive here, that they're working with us with UMass. So it's a very collaborative relationship. One of the things that people wanted to be reassured is that the services we have at the Cancer Center were going to stay here, and we were very confident that we could state that. So that was a big positive for us.
Yeah, because one of our claims to fame was that most community hospitals, I hope I'm saying it right, would have a relationship with one,
Yeah,
maybe two
right.
institutes, and we had like 3 or 4.
We had 4. Yeah, we have 4. We still have 4. So, actually, we're having more relationships now with UMass. Dana-Farber is still a big presence and growing. Boston Children's is here as well, and we still have some services with the Brigham. So it's all very positive. And again, for me, in the hallways, in meetings, the patient's always first. So if you walked into a room and people didn't have their jacket on, you couldn't tell who worked for everybody. And I think, that's a little bit of an art, but it's really a credit to the character of everybody that works here. So, and then the fifth component of that is MRPG and their physicians. So we still call them MRPG because, again, you go to see your physician, you can't tell really that there's a big change. The big change was when we joined their electronic record, but that's still, kind of epic. So there are things like that have changed, but in terms of medical care, it's
We'll talk
the same.
about Epic, that small investment that you had always talked about. But MRPG, is it still got the flavor, the feeling of MRPG, or is it now UMRPG?
Well, we're part of UMass Memorial Medical Group, so MRPG is just sort of a division within that. So,
Yeah, but Pat, sorry to interrupt.
yeah,
I'm more worried about the culture.
yeah, no, I think,
Legally, how you
Yeah.
structure it, and that's an ed department, how you pay the bills.
yeah.
But how's the culture
No,
holding up?
Yeah, I think out at the sites, I think they feel the same. I think there's some, certainly moving to the UMass EMR is a change, and there are certain other changes. But I think on a day-to-day basis, everybody's working with the same people. There's no other major changes, so I think it feels, the same. I think for patients, they're going to the same places, seeing the same docs, same nurse practitioners, same staff we've always had. There hasn't been any great turnover. We still have the same people and the same longevity, yeah.
You would think with this kind of merger, acquisition, whatever you want to call it, that some people would bail out.
Very little. Very little.
Yeah, I think, kind of at both the hospital and the group level, there's certain administrative services that have kind of changed and have moved more to a corporate kind of function, HR, finance, marketing, those type of things,
that's any
IT.
acquisition or merger.
Yeah,
You got an accounting department.
right,
You're not doing anything different, you're just adding people.
correct, yeah. So I think if you said to me, in terms of joining UMass, what's been the first big change that the community's known? And it hasn't been like we've closed a service or so-and-so's left. Actually, it's been the insurance contracts. That took a while to unfold, a lot of it back in January. And so Mass General Brigham and UMass they kind of do their own thing in terms of insurance. And actually, UMass is a little bit more rigid in terms of if you're a subscriber of an insurance plan, you have to be in a contracted plan to routinely see patients. So we tried to really communicate that. So like for Medicare Advantage plans, if your primary care physician would need to be in a UMass plan. So that was something that for patients that they had to pay attention to and adjust. So we tried to communicate that as best we can. So
Did many patients have to cross over? I mean, decades ago when I moved companies, all of a sudden the primary care physician I had been going to for years wasn't in the plan.
Yeah.
So I had to change.
Yeah, I think the vast majority of patients had plans that were common to both MRPG prior to the move into UMass and after within the UMass Memorial Medical Group. It was a small percentage, but that small percentage still were, some of them had been patients for quite some time. So it was painful for them. So therefore it was painful for our providers who had long-standing relationships and the staff. So even though percentage-wise it was small, it still was a tough transition, right? Because of, especially on the primary care side where you have that long relationship. So yeah, it was probably the most painful part of the transition, probably from the front line standpoint, is having to say goodbye to some kind of long-standing patients.
Well, it seems to be pretty seamless because, as I mentioned before, I just got the surprise that my undiagnosed tremor became diagnosed as Parkinson's. So I went to the Hill Building and met with a Parkinson's or a neurological physician. And he wanted me to get a second, I won't say a second opinion, but a more specialized opinion. Next thing I know, I got an appointment at UMass Medical in Worcester. We didn't know the difference, except I had to drive there. The records were there and everything just seemed to flow. So from that point of view, congratulations.
thank you.
Well, the nice thing, well, you mentioned the same medical record for the first time ever, MRPG and the hospital will be on the same electronic record. So you go from the outpatient setting to the inpatient setting, the providers will have the same access to the same
Now,
record, which has never been the case before.
I'm sorry to be mean, but is the epic of epic coming to fruition?
Well,
Not yet.
Not yet, not yet. We've learned that Epic in the different systems is different, but we're on the same Epic. So
An epic is the electronic medical records system.
Right,
correct.
right.
Can you
The
exist
brand.
without it?
Well, we existed before, but it was hard work. So the group, the hospital, at times the ED were on different systems, and so that meant if you came into the ED and they changed your meds, they would change it in the ED system, not in your physician office. Now it's changed in one system, and so that follows you. So that's like an example of one big change that's positive. So could you exist? I mean, can you exist on paper? Yes, but it's not as efficient and it's not as safe. And I think that's a big part of. Previously, the hospital could not afford to get into Epic. We weren't big enough to get into Epic, and so joining a system that was one of the commitments from UMass is that they were going to put us on the
And when
system.
you say cannot afford, going to an Epic system, that's not $300 investment.
No, it's 40+ million. in terms
$40
of IT.
million.
Yeah.
I mean, that just doesn't seem feasible for a community hospital.
Right.
But I'll admit, it's a lot easier now. I get little reminders. You have an upcoming appointment, fill in the blanks, and that way when I show up, I'm already pre-registered. I don't have to call. I used to have to call the 2222 number
The call center.
call center.
Yep.
Now all of a sudden I do everything online, and when I show up, I don't even have to discuss the billing. It's already taken care of. And that seems to be working because I went to Worcester and they already knew who I was and how to get my money. They already knew who I was and how to schedule me. So for that part of Epic, congratulations again.
Thank you.
$40 million.
Yeah.
Ouch. One of the biggest challenges you had mentioned years ago, and it's been consistent in all of our shows, is getting primary care treatment was the biggest challenge. Is it still?
I would say more so.
More so?
Yeah, especially, when you talk about primary care, you talk about family medicine, internal medicine, and pediatrics. We're doing okay with pediatrics because pediatrics, you might have someone for 18, 22 years. Occasionally, you might kick someone out when they get to be 24 years old. Say, okay, you're not a
My
you're not a
oldest
child.
daughter got
Right.
the
Yeah.
the pink slip
Right.
saying, Alexis, you're 26 years
Right.
old, 24, whatever it was.
Yeah.
You're no longer a ped.
Right. So you know what I'm talking about. But you think of an adult, they join an adult primary care doc in their 20s and they live till their 90s. That's 70 years with an adult primary care doctor. So there's more demand for adult primary care doctors than there is for pediatricians, just based on you spend 20 years life expectancy is almost 90 years now. So you have 20 years with a pediatrician, 70 years with an adult doc. The demand is just crazy for adults. So let's talk about family medicine and internal medicine. Almost no one who trains in internal medicine now goes into primary care internal medicine. They almost all go into either a medical specialty after their internal medicine residency, or they become what's called a hospitalist. They work in the hospital taking care of inpatients. It's shift work. They leave work and there's no work to do at home. It's much more attractive. So even UMass, which was established as a medical school for primary care, probably 1 or 2 out of 24 internal medicine residents end up doing primary care. So there's almost no internal medicine candidates. I've hired a lot of people in the 7 years I've been in this job. I think I've probably hired 2 or 3 internists, and none of them, early career. Family medicine is the other one, doing better there. But I'm really concerned because, I think we have, the statistics are in Massachusetts, 1 in 3 adult primary care physicians is over the age of 60. And, we're at MRPG, we're at least that, if not more. I think we have 11, I think I counted recently, I think we have 11 internal medicine docs that are 60 or over.
But that's a scary movie, Pat. I mean,
Yeah.
if you're not replenishing the supply
Right.
pool,
Right.
where are we going?
Right. So where we're going is nurse practitioners and physician assistants. So we call them APP, Advanced Practice Providers, and more of them are taking over the role of primary care providers. It's been probably close to 10 years, if not more now, that the insurers are recognizing and credentialing APPs as primary care providers. So if you have an insurance that you have to choose a PCP, you can choose a nurse practitioner or a PP or a PA, physician assistant, as your primary care provider. And we've had nurse practitioners and PAs as primary care providers for probably closing in on 10 years now at MRPG. And I think more and more we're going to be replacing our retiring internists with PAs and NPs. And the ones that we have now in our group are doing a tremendous job. They probably can't carry as big of a panel of patient as our physicians do. So, it might take, 1.5 or 1.3 nurse practitioners or PAs to replace a doc. or in some cases maybe even 2. But they do an excellent job.
Well, I mean, I think of my cardiologist. And with my body falling apart, I'm touching all the bases of your organization.
Thank you.
Dr. Shine is always there.
Yep.
But I think 2 out of 3 times, I see the, I don't know, nurse practitioner or whatever
Yep.
Michaela is.
Yep.
And I don't see any downside to that
Yeah.
personally.
Yeah.
I feel as comfortable, because I got to admit, the first time that I expected to see a doc,
Yep.
and I saw a practitioner,
Yep.
I was wondering, okay, is this the JVs?
Yep.
But after a while, you start finding out that I don't see any difference. I'm sure that in rare cases, they know their limits and they would bring in Dr. Shine immediately.
I mean, I think that's the key, is knowing your limits, and I think it's all about the individuals. And, you know, I've had nurse practitioners in my career that I think have been better than some of the doctors that I've met through my career, and vice versa. And, you know, as a doc, you need to know your limits too. I've practiced family medicine for 25 years. I needed to know my limits, and when I needed to ask, you know, a specialist to help. Same idea with the primary care NP or PA. They need to know their limits, and they need to know when to ask, you know, a colleague primary care physician or a specialty physician when they need help. So I think if you follow those guidelines, you're going to do fine. And our patients who see our NPs and PAs, I think, are very satisfied, and I think they're taken care of very well. And I think that's the future. I think there's going to be more and more NPs and PAs, and, you know, maybe more one physician in an office with multiple NPs and PAs, and they'll be able to do 95% of the work without any consultation with a physician.
And I think that's where the trust comes in. Because when I was in the Hill building, and they said, yep, you have Parkinson's, and they put me through the tests and all, and said, we'd like you to go to Worcester and meet with a Parkinson's specialist. I had no idea why. But it's kind of like when I failed my stress test, and they said, you're going to the Brigham. You're going to have a bypass, or we're going to test you, and if you need it. At that point, you're vulnerable enough that you just have to trust. And I think the system in Milford still earns that trust.
Yeah, and we have a couple of our sites that have done a really nice job of training and bringing along newer nurse practitioner PAs who are just graduated, because it's not for everyone to train someone who's just finished their formal training. But we have a couple of sites and a couple of docs who really do a great job, and we're looking to formalize that a little bit more, maybe extend some careers of those docs with maybe less of the grind of doing primary care every day, seeing patients, and more of the oversight and training of the new NPs.
But help me understand, why is being a primary care physician not top on the list? Is it fame, fortune, workload? It's got to be a reason.
Yes, yes, and yes. You hit probably most of them. Yeah, one, probably money, right? You go through college and medical school, you have huge financial debt, and primary care make relatively, now I'm speaking relatively, you know, compared to other medical specialties, are on the low end of the pay scale. I think they spend a lot of time doing non-direct patient care related work. They kind of are the owners of the medical record, if you will. So they're kind of responsible for the accuracy of the medical record, not just the note for the day you see them, but all the lists and all the other parts of it. They're kind of they feel like the ownership of the overall accuracy and neatness of the medical record, if you will. I don't know, you know, that's where everybody goes with all their questions. You know, they go to their primary care. They don't typically go to their specialist for their questions. So a lot of the non-patient, direct patient, non-reimbursable kind of work goes to the primary care. So, yeah, it's not the glamorous job. So that yeah, you're right. Fame, fortune, and I forget what was the third.
Workload.
Workload, yeah. I think all those things combined.
Is there a limit on archival of documents? I mean, I think of the ultimate was Los Alamos Labs, where they first said they were going to maintain all the records, the patient records, for 25 years. In the 24th year, they had a meeting and decided to extend it to 50 years. In the 49th year, they had a meeting and decided to extend it to 75 years. Is there ever an archiving limit?
It's probably less of an issue now that it's, electronic and cloud storage now where it is as opposed to paper. I think if I'm not mistaken for adults, it's a 7-year time frame. I think that's the concern, the biggest concern is liability, right? And risk, medical legal risk. So I think from, 7 years is from a legal defense point of view. It's longer for minors. So if you're if you're a minor, it might be limits longer than 7 years. But for an adult, I think you have to keep them for 7 years from the time that you.
But do you
create,
keep them only for 7 years?
I think we keep them longer. I mean, we probably have paper records that are in storage somewhere that are much older. But again, at this point, we've been on medical records, on electronic medical records for, at least 15 years, if not 20. The storage is, it'd probably be more, the work to purge older electronic records would probably be as costly as it is to buy Epic again. So the storage, I think, is probably so much cheaper to just buy more storage than to try to purge older records.
But as a patient,
yeah,
should I request my medical records and store them myself, or?
I don't see any need to do that. You can, unless you're seeing a solo person who's going out of business and you don't know where those records are going to end up. But if you're part of our system, there's no reason to.
But are there really any solo people left?
I think they're pretty rare.
Yeah.
I can't think of any off the top of my head, but.
No, I remember a friend of mine that I went to school with started explaining to me, he was in a solo practice.
Yeah.
And when he said, okay, first of all, I got to pay $300,000, $400,000 for med school. Then I graduate. I go to set up my practice. I have to buy an office or a house and convert it. I got $400,000 or $500,000 worth of equipment I have to put in. He says, I got almost $1 million worth of debt before I collect $1. So is that even feasible anymore?
You don't see it. You don't see it.
I would think that's the basis
No.
of your business.
Right. And then the other thing is the contracts. You can't get the decent insurance contracts negotiating
solo,
for
yeah.
yourself.
Oh,
Right. So that's a huge part of it too.
Yeah.
well, that was one thing, Ed, you mentioned that we may have benefit when we go from, the little Milford Medical Center to the big UMass Medical Center, that we could see some purchasing benefits.
Definitely.
Has that come to fruition?
Definitely. So in terms of being part of the UMass Memorial purchasing system, that's something we adopted early. So in terms of, again, much bigger purchases, cheaper prices, so that's been a positive for sure.
So it had worked out.
Yep.
Something I noticed my last visit to my primary care physician. See, I have one.
Good.
Thanks to your office pointing out who I could go to. First of all, let me ask a question. If I'm moving to the area, I got a 90% chance I'm going to be taken care of by somebody that works for you. How do I find out who to sign up for?
Yeah, your best bet is probably to go to the UMass Memorial website and go to the Milford page, and there's a way to sign up to get on a waiting list, and to be a new patient with a new PCP. We do have a waiting list right now.
Oh, is that right?
Yeah.
And is it quicker with an advanced practitioner?
Most people don't
Specify.
don't say no. I'll wait for a physician. If they can get any primary care,
That's what I'm saying.
but there's a wait for anyone.
Yeah.
Yeah, regard whether it's an MD or an APP. Yeah, I mean, unfortunately, we're, we're just trying to. We've had a couple of surprise early retirements, and a couple of departures, and not, as I said, not so much luck with hiring. So we're trying. We feel our first priority is to our existing patients. That when someone leaves, we never want to say, sorry, we can't continue to take care of you. So we push the limit on making sure we take care of our own, if you will. So we've had to put new requests on a waiting list, and right now there's a waiting list.
Well, I had a friend who moved to the area.
Yeah,
And they went looking for a primary care.
yeah.
Explain to me what closed practice means, because they called me and said, did they go
Yeah.
out of business?
Yeah.
I said, no, I think it means they've hit their limit
Yeah.
of patients.
Well,
they
that's what
can-
it means.
Yeah.
I mean, everybody has a limit on how many patients they can take care of safely, right?
They're called panels of patients.
Right.
Yeah.
So, and you can define that many ways, but, you don't want to, you can, with the insurances, decide at a point where I can't take good care of any more patients.
I can take
So
care
you-
of 100 patients.
Let's say, yeah.
At a quality level that
Exactly.
I'm happy with.
So then you tell the insurance, all the insurance says, I'm not taking
Number
any more new
101
patients.
has to wait.
Right. And so when a practice, all the providers in their practice, that practice is closed to new patients until, and then, we look at, every so often, we look at attrition, moving, change of insurance to one we don't accept, death, et cetera, and, we replenish those. So we're always trying to add and get back up to a level, but, so we'll probably always have, I mean, it's a good problem to have, right? It's to have patients wanting to.
It depends if you're on the inside. If
Understood.
you're with Uncle Ed
Under-
and you're
right.
looking at capacity, that's a great problem to have.
Right.
If you're the patient moving
Understood.
to Milford saying,
Yep.
Yeah.
I need a doctor.
I would,
So what would people do?
I think they get on the list and they wait.
And if they need somebody in between, they go to urgent care?
Yeah. I know it's not a great answer, but
Well,
that's
no, but urgent
that's the
care
practical solution, and they'll,
It's
and,
become more and more accepted.
It's not,
yeah.
and you can get some virtual physicians out there.
I'm not comfortable with that
Yeah,
yet.
no, I know, but
Well,
that can get you through a
Yeah,
few issues.
The other thing that UMass has that we're starting to use with our retiring physicians is they have what's called a bridge clinic that is run by nurse practitioners, physician assistants, that take care of patients from the time they establish a relationship with the bridge clinic until their appointment with a new primary care. But
Oh,
you've got to
okay.
be able to, and it helps take the burden off of new primary care from having to kind of own, if you will, the patient before you ever see them. So let's say we do have a doc who's busy but says, I'll take some new patients, and they schedule to see you, Al, in December for your first visit. Well, then in October you say, I need my 10 medicines refilled, and they don't know you from anyone, and they're busy, and normally they'd have to say, call your old doctor who says, I'm not your patient anymore, or I retired, so they're not going to fill your medicine. And they say, geez, I don't have the time to look through your whole medical record to make sure it's safe. So they either just fill all your medicines, not knowing whether they're safe or not, or they got to take an hour or 45 minutes to review your record to make sure everything's safe. But in this case, the Bridge Clinic takes ownership of that.
Oh, nice.
Or if you call and you have a question or a concern, you have a virtual visit with the person there. They figure out what's going on. They review your medicines. They review what your problem is. If they figure that you need to be seen, they figure out where you need to be seen. They basically bridge the gap from now until you can actually get seen by your new primary care. So we're using that for, like, we have a doc who's retiring in September, and we're starting to schedule those patients with a new doc in MRPG, but she's got like 1,800 patients. So that's a lot of patients to spread within our group, and that's a lot of additional work for those docs before they ever see the patients. So the Bridge Clinic is going to take ownership of those patients after the doc retires until they all establish with their new doc.
1,800?
Yeah,
Is that a normal practice?
that's a high normal, but not abnormal.
So my estimate of 100 was not even
Yeah,
in
that
the
was
book.
pretty. Yeah, that was for example's sake only.
I was going to
Yeah,
say,
yeah.
I mean, the physicians probably wish they were back in the days of Dr. Cicchetti Capisi, where you
Yeah.
had 4 docs that took
Yeah.
care of the whole town.
Yeah, the only ones who have 100 are the concierge docs,
No.
right? Who charge $5,000 a year to be available.
Is that catching on, this concierge
I
principle?
I don't know if it's. I would say a few years ago maybe it was catching on. I mean, it might be stable now, but I don't see where it's growing by leaps and bounds. It's certainly not any kind of solution to our problem. It's worse. If anything, it's worsening our solution to primary care access, right? Because it's taken docs who might have 1,800 patients,
Down
and now
to
they're taking
500
care
or
of 500,
600.
right? So it's no solution for a public health problem, that's for sure.
And that's all private pay,
Yeah,
correct?
Yeah. The only one it's a solution for is the
physician,
doc, the
yeah,
physician themselves. Yeah,
If they can make as much money and only have
Or more,
a third the
yeah.
patients.
Yeah.
I noticed something that years ago, when my mother went to Dr. Farouk, all of a sudden he had a shadow. I guess it was somebody finishing med school who was being his scribe to take some of the paperwork. Because my understanding is that's the nemesis of most MDs, is
What?
not having enough time to spend with patients because they have to then spend hours doing paperwork. So they got their slaves to come in from med school. Then all of a sudden, this time I went into my primary care, and he asked me, I'm going to use an AI scribe. Is that okay? Help me understand, is we've done away with the med student now and we have AI scribes?
You've got it down pretty good.
yeah, yeah. Yeah. Well, I wouldn't say they were slaves because we had to pay them even when they were med students. So.
Yeah, but I understand the rate for med students
Yeah.
and interns.
Yeah,
And,
no, it was still it still added up. But anyway, yeah, we went from live scribes in the room to, at least at MRPG. Then we went to recordings that we sent overseas that were
to be
protected.
transcripted.
Yeah, that were transcribed overseas and sent back. To now we're doing what's called ambient listening AI. So it's like some of the AI, lots of the AI that we see now. It's able to listen to a conversation and pull out the important data and sift out and remove the conversational parts, and it creates a document that, just like you would do a live scribe would, or prior to using live scribes you would dictate, type prior. So it's a huge improvement and a time saver. And it's only going to continue to improve. And it learns as you go. It learns each individual provider's style, and it gets better. The more you use it, the better it gets. So, I would say with the improvement even in the last year or two with this ambient listening, I would say that the vast majority of patient encounters, at least in areas where it's quiet and it's a patient and a provider in a quiet area, I would say within the next 2 years, probably the vast majority of encounters are going to be documented in that way. That's how good it is.
But he can't give you the look. Dr. Shine will look at me
Yeah.
and say, are you giving me my 5 days of 30 minutes exercise?
Well, yeah, it can't, you're right. It can't document that Dr. Shine gave a stern look, right. But what patients are saying is that instead of seeing the back of their provider's head while they type into the computer, they're actually having a conversation with their provider, and they feel like they're listening and paying
It
more
feels
attention.
like there's a lot less dead time.
Yeah.
When I'm with Dr. Williman or Dr. Shine, I'm talking to them, or they're
Yeah.
talking to me.
Yeah.
Not, like you say, giving them time to, wait a second while I type this
Right.
in.
Right. So I think it's a huge game changer. Now, it doesn't solve all the problems of department, but it solves one of the major time issues.
How are we doing in the ED?
Good. As you know, we've got a great emergency department. The group that's been there, led by Dr. Hopkins, has been there for a while. It's a vote of confidence. It's a desired place for physicians to work. So they've always got like a waiting list of usually UMass residents that want to come
To work in the ED?
Yeah, yeah.
I would think that would be not a place I want to work with the chaos and.
Yeah, some people thrive on it, and you see, I think in terms of job satisfaction, you see a lot of different varieties of things. So it's, for new, particularly for like new nurses, they will often start in telemetry or ER. So it's a busy place. And then, in terms of our emergency department, so we have residents that come from UMass, so they get to work there. Again, our big, physicians are such an important part of Milford Regional. Getting physicians to come to Milford is a big part of what's made us successful. So employing physicians, having these relationships with the academic medical center, but getting them to come here. And so what's happened to the emergency department is we've had residents there. So they come here, they spend a few years here, so they already know us. They like it. They've learned a lot. It's a great environment. So it's been self-fulfilling, both in terms of physicians and nurses.
Capacity-wise?
We have a big emergency department, so 50 rooms is really big. It's enough to take care of emergency room patients. When it's not enough is because the rest of the system has backed up. And so that can be in Worcester or Boston. It can be upstairs in our hospital. It can be the nursing homes. Everything you learn flows through healthcare. And so a bottleneck one place creates bottlenecks
I was going
elsewhere.
to ask you, one of the issues that we ran into was talking about accepting patients. And is the nursing homes or whatever they're called,
Yes, skilled nursing facilities.
skilled nursing centers,
Yeah.
ran out of capacity.
Better right now. Well, what they typically run out of is they run out of staff. So if they don't have staff, they close capacity, they close beds. So I would say, relatively speaking, better, stable right now. So patients are generally moving through our system, and that's also one of the systems with UMass. And I like Pat's quote. I've used it. I probably don't do as good a job, but when a patient that you would see in the office, you need to send to the hospital, you call the department, and someone writes down what he said. It gets handed off to someone else. Now there's an electronic process to communicate right from the physician or advanced provider. I'm sending this patient to the ED, and so your doctor is now communicating exactly what the ED doc and nurse needs to know. So that's, again, another improvement of Epic in what they call the track system of UMass.
But financially, Ed, okay, I'm in the medical center here in Milford. I'm at a point where I can be freed to go to a skilled nursing center. And the nursing center says, can't take them right now.
That's a problem for us.
I was going to say,
Yeah.
You can't just send them home.
Right. Typically, it's the patient on the floor that's going to the skilled nursing facility. So the patient in the ED wants to go upstairs. They can't because that patient's there.
So it's a backup all the way
So it's a
through.
backup all the way.
Right
Yeah.
into the waiting room.
Yep.
But financially, is that neutral for us, or does that hurt us?
It's a killer. No, it hurts us. It hurts us.
So to say,
Because we people don't always realize this, but you get paid usually per visit for inpatients. So you get paid one visit. If they stay 3 days, 5 days, 7 days.
so you're going to get $100 from me coming in.
Right.
If you get me out within a day, you're doing well. If all of a sudden you got to keep me for 3 extra days
Yeah.
finding a bed,
There's
Still 100.
there's
Still
fine
100.
tuning. That's a generalization. There's fine tuning for outliers both ways, but in general, that's a principle. So so it hurts.
but on the nursing side, on the skill side, I remember them saying that the transfers helped them. The
Yep.
rehab helped them because Medicaid was paying $50 less a day than it is.
Yeah, the types of
Cost.
patients matter to them. We don't kind of get into that as much, but, yeah, if they're not able to take patients, that, that kind of hurts everybody, so.
But there's nothing you can do about it, right?
Right, right. And then sometimes in Worcester or Boston, if they're backed up and we have sick patients and they can't take them, that hurts as well. Because that takes, we have to monitor those patients, it takes resources. So what we like is a healthcare system that's working really well. And I'd say right now, we've had, particularly during COVID and after COVID, and a lot of it's been staffing. It's not physical bricks and mortars. It's been the staff. But right now, relatively stable.
But now staffing, is it that we're not making, this sounds terrible, but we're not producing or making enough physicians? Or is it they're specializing in this areas that, like primary care, we mentioned, nobody
Yeah.
wants to do primary care, not nobody, but the vast majority don't want to do it.
Yeah, I don't think we have enough physicians in anywhere. I hear about other specialties that it's difficulty, and UMass has been having a real hard time in radiology, urology. So there's specialties too. So it's physicians across the board, and I think there's a lot more people working less than full time in medicine now than there were 15, 20 years ago too. So, the same number of medical school graduates working less full-time positions, more part-time, creates
I
less.
get in trouble for saying this, but when we meet with students at Holy Cross to give them career advice, a few of them have said, I'm pre-med. My question is why? And what do you mean why? My opinion, if you have a passion for medicine, it's a great profession. But if you're doing it to make money or other things, there's a lot of simpler, easier ways to make as much money without killing yourself and without the responsibility.
I think it's true in really in any field. The saying, if you like what you do, you don't work a day in your life. And so
Right.
I think, sometimes the bottlenecks are non-physician services. So, honestly, in terms of, the population is getting older. The technology that's here today, they can detect more. So, CAT scan, as an example, has been an acute shortage of folks to run the units. Now, we're doing more CAT scans than we've ever done because they're more sophisticated. They find more, they tell you more, they're more of a tool. But the schools haven't been able to keep up in terms of producing graduates. And it's honestly, as we've kind of talked, it's different generation today in terms of all work ethic and what folks kind of want to do and demand. So it's all of those challenges in terms of
Well, the whole
supply.
hospitalist concept, physicians who want a life, that they
Right.
actually want to go home and
Yeah.
spend time with their families.
Yeah.
Isn't that why the hospitalist occupation came about?
Yeah, the hospitalists work hard. I mean,
No, I understand, but-
yeah, I'm careful because I talk to physicians of every specialty, and it's funny. Everybody thinks they have the most difficult job, and
Isn't that the truth?
and I've come to learn that unless you've walked in their shoes, you really can't compare. So I don't know that anyone has an easier or a harder job. That's what I've learned in the years that I've been doing this job. I think hospitalist medicine came out of you couldn't do a very good job taking care of patients in the hospital, showing up at 6 in the morning and waking up your patient and evaluating them at 6 to 6:30, then going to your office all day and then coming back to the hospital on your way home. That's not a good way to take care of patients in the hospital who are your sickest patients, which is what we did in primary care prior to there being hospitalist medicine as a specialty.
You still remember that?
I did that. I did that. Yeah,
Yeah.
that's how old I am. You have to be in the hospital during the day when the patients, and at night when your sickest patients need you, and that's really why hospitalists. Yeah, do they work shift work? Yeah, docs work shift work too, but those shifts are pretty darn intense. Do they get to leave their shift, and when they left their shift, they're not bringing work home with them? Typically, no, but their shifts are pretty intense.
Well, I'm not questioning the
Yeah,
intensity.
yeah,
It's just
yeah.
must be a nice thought that you get to go home and have dinner most nights with your family, and not be on call going back and forth.
Yeah.
Yeah,
Yeah.
it's a different, there's different trade-offs. Some things are better, some things aren't as good. And I think, really stepping back, the big thing is, the patient that's in the hospital today is sicker.
Yep.
The technology is more complex. It's not something that you can, as Dr. McSweeney said, at 6 in the morning, you can direct with the phone call. You've got to be there and kind of on it. So,
Well, I mean, we're all living longer. And, as my wife said, well, don't worry about the Parkinson's. The diabetes will get you before then.
Jeez.
So you sit there and say, my father wouldn't have lasted as long as I have.
right,
These are all chronic diseases, things that a generation ago were all lethal. Now they're chronic diseases. You live a long time and you manage them. Yeah.
So, Ed, what's the big challenges coming up in the next year?
We're relieved from most of the big integration is done. So we're starting to get back to kind of more of the basics. I think in terms of a big electronic record, for example, like we don't have that in front of us. So the UMass system, I think their big goal is really to take care of sicker patients in Milford and to appropriately move care to the community. And so part of that is going to be our mission. Part of it we're anticipating will be expansion in terms of the things that we can do here. But we haven't completely nailed all of that down right now. I think, as we kind of wind down our time, I mean, for us, being, roughly 20 months out from the corporate affiliation, I mean, we feel overall things have gone really well. And part of our goal, our mission here is to continue to take care of the community. And so what we had before independently was really teamwork, getting physicians to come to Milford. And we're really happy with where things are right now because we've retained a lot of what's made us special. And now we want to kind of continue that. And we have a lot of challenges. Physician attrition and retirement is going to be, is just an example. But we want to keep care in the community, take good care of patients, and have these relationships, particularly in Worcester, that we send our sickest patients there. And so it's really quite simple. Take good care of patients, take good care of our community. And we're appreciative of our community because they take good care of us when we've had a need.
Well, let's hope that when we have a year in the future, we're having the same discussion saying no major problems. We don't have diseases that are flaring up. We don't have issues. I mean, I remember the emergency room where my daughter had to spend hours and hours on a bed out in the hallway. Now you're talking about a 50-bed emergency room.
Yeah. And again, if the system backs up, we could have that. So we want to kind of avoid that. So.
Well, thank you for everything you're doing. And as I say, the fact that I can't come up with one major issue that I can say, Ed, you forgot this one, says a lot about your leadership.
Yeah. Well, thank you. And
Thanks
again,
for having us.
I think Pat and our teamwork between the hospital and MRPG. So we want to keep that going.
And to our 6 loyal viewers, thank you for joining us. The Milford Medical Center, or we used to call the Little Red Hospital, has come a long way and continues to serve us very well. I can't say enough about the medical treatment that my family's gotten, and I can't ask for better. So to all of us, good night. May God bless. May tomorrow be a healthier day than today. Thanks again.